Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Mark Saleh. Dr. Saleh completed his undergraduate education at the University of Western Ontario in London, Ontario, Canada. He earned his Doctor of Medicine degree with honors from the University of Toronto in Ontario. He then performed postgraduate training in urology at the University of Ottawa, also in Ontario, Canada. Dr. Saleh is board certified with the American Board of Urology and is certified in urology as a Fellow of the Royal College of Surgeons of Canada. Dr. Saleh currently practices medicine with Washington Township Medical Foundation in Fremont.
Good afternoon, everyone. Thank you for coming. As you can see, today we're going to be talking about prostate health and prostate cancer. So that includes prostate cancer screening and some of the controversy that is out there recently that you may have heard about in the papers or in the media about prostate cancer screening using PSA, and I'll explain that in more detail later. So we're going to start off the session talking about prostate anatomy, where the prostate is, what it does. We're also going to talk about BPH, or benign enlargement of the prostate, that affects many men. And then we'll talk about prostate cancer and prostate cancer screening. So what is a prostate? It's this walnut-sized organ that sits at the base of the bladder. There's your bladder. That's the prostate. The seminal vesicles are also right behind the prostate, and they're involved in sexual function, releasing a lot of the fluid that comes out in the ejaculate. The urethra that carries the urine out of the bladder runs right through the prostate and then out through the remainder of the lower urinary tract. And that is why that prostate enlargement can affect urinary function in so many ways. So BPH, what is it? It stands for benign prostatic hyperplasia. Many people call it hypertrophy, but it really is a hyperplasia. The difference is in whether the cells get bigger, which is hypertrophy, versus hyperplasia, which is an increase in the number of cells in the prostate, which is what actually happens on a pathological level. So the prostate continues to enlarge throughout life, and by multiplying the number of cells. That enlargement affects most men at some point in their life, and that's genetically determined. It's obviously more common with age. As men get older, the prostate gets larger and larger and causes more symptoms. And it can affect the urination and also the quality of life as a result of those urination problems. On the left here, you can see a normal bladder. This is normal bladder thickness. The urethra is going through the prostate, and this is a normal prostate with the urethra wide open. It's not, the flow of the urine is not restricted. This is BPH. So this is an enlarged prostate. As the prostate enlarges outwardly, it also enlarges inwardly and constricts the urethra. There's a difference in the lumen, or the size of the urethra. That causes the pressure inside the bladder to go up. The bladder has to work harder to generate that same urinary stream that it used to, or even anything close to that. Now, just like any other muscle in the body, resistance causes the muscle to get thicker and bigger. So when you're working out and you're lifting weights, your biceps will get bigger as a result. That's the whole idea. That's a good thing for a skeletal muscle. It's not a good thing for an internal organ like the bladder, because it's going to produce some of the symptoms that we're going to talk about later. Again, as the prostate enlarges, it constricts the urinary tract and the urethra, causing the symptoms. This is not intuitive, but the actual size of the prostate doesn't always correlate with the symptoms. The reason is that the prostate may enlarge in different ways. So if the prostate enlarges mostly inwardly, even a small amount of enlargement can cause significant symptoms. Some men with really large prostate may still have a rather open urethra, and the symptoms may not be as bad. So the physical exam, the size of the prostate doesn't always correlate, and that surprises some men, but that's the explanation. So some stats about BPH. It affects more than 26 million men each year in the United States. The prostate grows to a normal size by the time you reach puberty, complete puberty, and that's about the size of a walnut. Usually weighs about 18 to 20 grams at that time. It continues to grow, stimulated by testosterone throughout life. How fast it grows is genetically determined. So some men will have problems in their 40s and 50s. Some men may not have any symptoms until their 70s or 80s. But basically, every man is going to have a problem with their enlarged prostate to some degree. So what are the symptoms? The symptoms are either caused by obstruction to the flow, so a weak flow, or by the irritative symptoms that the bladder may experience because of the obstruction and that hypertrophy or that thickening of the bladder wall. And it could include a weak stream, feelings of incomplete emptying, frequent trips to the bathroom during the daytime and nighttime, actual incomplete emptying and an elevated residual in the urine, and in what we call intermittency, or stopping and going, or feeling like you have to do double voiding to complete your urination. The consequences of BPH include the symptoms that we just talked about, and the acronym that we use in urology is LUTS, or lower urinary tract symptoms. But it can also lead to either acute or chronic urinary retention. Acute retention is in somebody who is just getting by. The prostate is causing obstruction and the bladder is compensating, but barely. And then something happens. Maybe they take an over-the-counter medication, like a cold medication, that causes constriction of the smooth muscle in the bladder neck. Or they have an infection, prostatitis or inflammation, that causes that swelling to finally shut down the urethra, and then they suddenly can't urinate. The bladder gets really full very quickly, and that's a very painful condition that requires an emergency insertion of a Foley catheter. Chronic retention is more of a slow, gradual enlargement of the bladder with an ever-increasing residual in the bladder that eventually can cause serious problems like kidney failure, because if it happens silently, and we used to see this a lot more before people had regular medical care, the bladder gets bigger and bigger, silently, because it is a gradual process, so it's not painful. That pressure builds up and backs up into the ureters and then into the kidneys, and then the kidneys can't filter anymore against that pressure, so you get kidney failure and renal failure. Detrusor, the detrusor is the name for the bladder muscle. Detrusor instability or an overactive bladder results because of that hypertrophy, that thickening of the bladder wall that happens because of this increased pressure inside the lumen of the bladder. As the bladder works harder, it gets thicker and then becomes irritable and unstable. So what happens is that the functional capacity of the bladder is reduced. And instead of waiting until it's 400 or 500 milliliters full of urine before giving you the signal that it has to go, it might irritate you and feel like you have to void at 100 or 200 milliliters. So you obviously go more frequently. Urinary tract infections can occur because of the elevated residual. So even though the bladder is working harder, it's not emptying completely. There's always some urine sitting at the bottom of the bladder. And that acts like a little culture medium that acts to promote infections. And it could also lead to bladder stones, as chemicals in the urine precipitate to the bottom of the bladder in that residual. They can form stones that get bigger and bigger. Bleeding can occur from the prostate. The enlarging prostate requires more blood supply, and those bigger blood vessels aren't always normal. They might be close to the surface, they're fragile, just straining or even constipation, straining to have a bowel movement can cause some bleeding from the prostate. And that bleeding at times can be quite severe. The blood, as you may have seen in the picture before, the prostate is very close to the bladder, and the bleeding ends up going into the bladder and forming blood clots that can cause obstruction out to the flow and cause retention. So as we mentioned before, the prevalence, or the percentage of men that have BPH, increases with age, and so do the symptoms that go along with that. So for example, In people under 49, nocturia, or getting up at night, is less than 5%, or in that range. But in an 80-year-old, 70 to 80% of men will have nocturia. They will have to get up at least once at night to urinate as a result of this obstruction. And that goes along with the other symptoms, the weak stream, the urgency, and the frequency as well. So what kind of impact does this have on men? It impacts the quality of life as a direct result of those symptoms. If you're getting up every 1 or 2 hours to urinate, you're not getting enough sleep. Some men can't go back to sleep. They're chronically tired. They're sleepy during the daytime. They don't like going places where there's no bathroom, or where they're not close to a bathroom, where they don't know where all the bathrooms are. It limits their activities. And it may limit outdoor sports. You might not want to go golfing with your friends if you're the only one that has to run to the bathroom every hour. So you have BPH. What are your treatment options? The slide is a little busy, but we'll summarize it quickly. Watchful waiting, or doing nothing, is a valid option for most men. Basically, if there are no complications of BPH, the serious complications, the infections, the stone, the hematuria, the retention, then what determines the need to intervene is the patient and the patient's symptoms and how the symptoms are impacting their life. So if the symptoms are mild and the patient can live with them, then we live with them and we don't do anything. We just keep an eye on it and monitor on an annual or semi-annual basis. If they are bothered and the symptoms are relatively mild, we consider medications. Two large categories of medications are the alpha blockers and the 5-alpha reductase inhibitors. The alpha blockers, such as Flomax or Tamsulosin, Hytrin, Cardura, Uroxetrol, Rapaflo, they all work by the same mechanism. They relax the smooth muscle in the bladder, neck, and in the prostate. The prostate is a gland that produces fluid, but it also has smooth muscle that surrounds the outside and within the gland itself. And as the prostate enlarges, that smooth muscle tone increases and causes a functional obstruction of the urethra. So as well as the fixed obstruction you have from the enlargement, the tight prostate causes obstruction that can be relaxed almost immediately by alpha blockers. So you see the effect of those medications very quickly when you take them. The 5-alpha reductase inhibitors actually cause a decrease in the size of the prostate over time. And they act by inhibiting the effect of testosterone on the prostate. Testosterone doesn't act on the prostate directly. It has to be converted to another similar hormone by the enzyme 5-alpha reductase. If you inhibit that enzyme, you inhibit the effect of testosterone in the prostate without changing the testosterone level in the serum. They're usually indicated for people with enlarged prostates above, say, about 50 grams, and whose symptoms are not relieved by the 5-alpha reductase inhibitors alone. So you often use them in combination. For somebody who has more severe symptoms or maybe can't tolerate the medications or doesn't want to take medications the rest of their lives, you can go to the minimally invasive therapies such as TUMT or the transurethral microwave therapy. There's also TUNA or transurethral needle ablation. These are basically in-office procedures that involve heating the prostate by either putting a catheter in the urethra that is situated at the prostate. And with something like microwaves, you heat the tissue. And if you have ever cooked a steak, you see that the steak shrinks when it hits the heat. So a lot of things, the proteins shrink with heat. So you're basically cooking the prostate and shrinking it. And that causes it to separate away from the urethra, and it opens up the urethra. That can work for some men, and it is relatively temporary. After a few years, the symptoms are going to return, and you may need another procedure at that stage. For more definitive treatment and for more permanent treatment, you usually have to go to the more invasive procedures such as the laser, photoselective vaporization or the green light, or the transurethral resection of the prostate, the TURP or the Roto-Rooter is another name for it. That is a gold standard. And that gives you the best results. An open prostatectomy, where you actually have to make an incision and remove the bulk of the prostate, is done in really large prostates that may not be safely done with the minimally invasive or the mildly invasive procedures. This is an example of the result you might get with surgery. This is the view I have when I do a scope, when I look through the urethra, and I put the cystoscope through the urethra, and I get to the prostate. This is the right side of the right lobe. That's the left lobe, and in the middle is the middle lobe. And that tiny little dark area is the urethra. That's the only tract that's open right now for the urine to flow through. Immediately after the surgery, with the laser or with the TURP, all this tissue is removed and all this black area is a wide open channel for the urination. You actually have to cut through the urethra. There's no way to get to the prostate tissue without doing that. So what you have is a raw surface here that after a few weeks or a couple of months will get lined up again by the transitional epithelium that's found in the bladder and in the urethra. Once that happens, a lot of the symptoms that you might experience after the surgery are relieved. And those will include some burning, a little bit of blood in the urine, some frequency. And then you have a wide open channel and the urinary stream is excellent at that stage. And it's usually a pretty permanent result. So prostate cancer screening. Prostate, bladder, this is the rectum, and this is how a digital rectal exam is done. The prostate is sitting on the rectum. So you can't obviously see it. And a lot of people ask me, well, do I need to do this? I've just had a colonoscopy for colon cancer. When the gastroenterologist is doing a colonoscopy, he's looking at the lining of the colon and the rectum for polyps. He can't see the prostate and cannot rule out prostate cancer. Finger exam can feel the back end of the prostate, the posterior end, that can tell us if there's a nodule, a bump, an irregularity that might be suspicious for cancer. Before the advent of PSA testing, this was the only way to test for prostate cancer. And so it had to be advanced enough, it had to be large enough for you to feel it before you could determine whether somebody had the disease or not. Now we use PSA, or prostate-specific antigen, which is a blood test that we'll talk about in more detail soon. There's a digital rectal exam, and it's usually a combination of the two tests. If you have an abnormal exam or an elevated PSA, that's usually an indication to be sent to a urologist for further testing, and that often involves a biopsy if the findings are confirmed. That's really the only way to tell whether there is cancer or there isn't. The physical exam and the PSA act only as a guide. Prostate cancer is very common. Many famous men have been diagnosed with it and have been successfully treated. So what is it? Like any cancer, prostate cancer is an abnormal cell growth. It often begins with one cell that has a genetic abnormality. It might have been genetically abnormal to begin with, and then usually there's an environmental hit, some chemical or some stress in the environment causes another genetic change, a break in the chromosome, a change in the DNA. So what happens is that the cell, that particular cell, doesn't follow the normal rules. Every cell has a rule that when you grow to a certain size or when you meet other cells nearby, you stop growing or you grow at a slower rate. Prostate cancer cells, any cancer cells don't obey those rules and they continue to grow. The other thing